Thank you for the kind introduction. I'd like to thank the organizer for giving me an opportunity to have a presentation in the APASL webinar. From now on, I'm going to present a case of middle-aged man with decompensated cirrhosis and its complications. I have nothing to declare regarding any conflict of interest. The chief complaint of the patients was abdominal distension, which was aggravated 3 days ago. A 55-year-old male patient with a history of hepatitis B cirrhosis, diagnosed 10 years prior, was referred to the emergency department of our hospital. He was on tenofovir disoproxil fumarate and was undergoing regular surveillance for HCC every 6 months with ultrasonography and blood tests. However, he did not show up for 1 year and stopped TDF on his own will. 3 days before the current admission, his abdomen has become more distended and swelling developed in both legs. In the emergency department, his vital signs were normal except bradycardia. He had jaundice, scleroicterus, and spiral angiomas. The abdomen was distended with dullness on percussion on the flanks, but non-tender. There was 2 positive symmetric pitting edema in the lower legs up to the knees. His initial blood test showed white blood cell counts of 7,600 per microliter, platelet counts of 41,000 per microliter, PT-INR of 2.02, fibrinogen of 97 mg per deciliter, albumin of 1.9 gram per deciliter, total bilirubin of 6.9 mg per deciliter, AST of 531, and ALT of 263 international unit per liter, sodium of 131 millimole per liter, and CRP of 4.25 mg per deciliter. HBe antigen was negative, and HBV DNA was 69 million international unit per milliliter. Investigation of the ascitic fluid showed serum ascites albumin gradient of 1.6 gram per deciliter, which was compatible with ascites due to portal hypertension. PMN count in the ascitic fluid was 1,839 per microliter, confirmative of the diagnosis of SBP. His MELD score was 23, and the Cliff SOPA score was 7. His dynamic CT scans and upper GI endoscopy confirmed the presence of cirrhosis, ascites, gastrolinear shunt with esophageal and gastric varices, and portal vein thrombosis in his left portal vein. We assessed that the patients had first HBV-associated decompensated cirrhosis complicated with SBP, second, esophageal and gastric varices with gastrolinear shunt, and third, bland portal vein thrombosis. So we plan to restart antiviral treatment for HBV reactivation, start empirical antibiotics for SBP along with IV administration of albumin, and perform endoscopic band ligation for esophageal varix. Here is the question. First, what is the treatment of choice for empirical antibiotic therapy? Beta-lactams or carbapenems? Second, do we need to correct coagulation abnormalities when performing any invasive procedure, such as paracentesis or endoscopic band ligation? Third, will you recommend anticoagulation treatment for portal vein thrombosis later? And if so, will you recommend warfarin or direct oral anticoagulant? Lastly, what are your recommendations for the management of gastrolinear shunt? Thank you for your attention, and I will come back later with case summary.
Thank you, Mr. Chairman and organizers. I'm really grateful to the leadership of APASL for asking me to participate in this really terrific program. To date, a majority of studies have focused on Western bis-nephrotic population. Relatively, there is a lack of research on the characteristics of Asian
As shown in this slide, the global prevalence of NAFLD is approximately 25%, although the prevalence varies among the various regions and ethnicities. However, interestingly, in
Hello, my name is Manal Abdul-Malik. I'm professor of medicine at Duke University, and I thank the program organizers for the opportunity to speak on best practice advice for obese NAFLD. The learning objectives for today's talk are to review the best practice for treatment of NAFLD in obese subjects. We'll cover diet, exercise, the importance of weight loss, the importance of management of medical comorbidities, as well as the role of bariatric surgery and endoscopy. I think this cartoon depicts the current management of the obese NAFLD patient, where primary care physicians and specialists are working very hard but not working in unison. The pin that glues us together such that we can have forward momentum and efficacy in caring for our patients at times is missing. The treatment of the obese NAFLD patient requires an integrative approach, a multidisciplinary team of patients where the patient is at the center of care. This can include a hepatologist, an endocrinologist, a nutritionist, or other specialists such as behavioral psychologists or physical therapists. Cardiovascular risk reduction is essential as our patients are at very high risk for morbidity and mortality, and management of cardiovascular risk, dyslipidemia, diabetes, hypertension, smoking cessation has to be integral to the care of the obese patient with NAFLD. We, of course, need to screen and treat comorbid conditions that perpetuate both NAFLD and obesity, such as sleep apnea. There has been success with very integrative weight loss centers for which there are specialists who can manage pharmacotherapy, endoscopic or bariatric surgery, and guide a patient in the risks, benefits, and alternatives to such interventions accordingly. Individualized pharmacotherapy for diabetes is important as optimal glycemic control has been demonstrated to potentially alter the natural history of NAFLD, as impaired glycemic control has been independently associated with fibrosis progression. And lastly, prevention strategies for those patients with advanced hepatic fibrosis such that they receive routine screening and surveillance for complications of cirrhosis such as varices or hepatocellular carcinoma and undergo vaccination. We've come to recognize that non-alcoholic fatty liver disease is dynamic and modifiable. Certainly those patients who have stage 2 fibrosis or higher are at increased risk for disease progression to cirrhosis and its associated clinical outcomes of portal hypertension, hepatic decompensation, diminished liver synthetic function, or liver cancer. Lifestyle modification is a must for all patients irrespective of where they are in their disease spectrum and has specific implications for those patients who are obese. We understand that there are genetic and epigenetic modifiers, environmental risk factors, as well as alterations in physical activity and diet. But those patients who have advanced disease certainly may be more appropriate for targeted pharmacotherapy, but ultimately the treatment of obesity and its associated comorbidities can modify the natural history of disease. In caring for the obese patient with NAFLD also necessitates care for their comorbidities such as diabetes, defining other risk factors which contribute to not only NAFLD but their obesity, as well as confirming the absence of secondary causes of fatty liver disease. After making the diagnosis of non-alcoholic fatty liver disease, the next most important step is risk stratification. Patients who are low risk for advanced hepatic fibrosis with a low NAFLD fibrosis score, FIB4, or low transient elastography of under 8, can confidently and comfortably undergo lifestyle intervention and in fact be followed in primary care. Those patients who have intermediate or are at high risk for advanced hepatic fibrosis with a NAFLD fibrosis score of greater than 0.67, a FIB4 score of greater than 3.25, or who have a FibroScan stiffness score of greater than 9.6, or an ELF score at baseline greater than 10 or 11, may have underlying advanced hepatic fibrosis or cirrhosis, and best practice would to ensure that we identify this and survey accordingly for hepatocellular carcinoma, screen for esophageal varices if a patient meets the Baveno criteria, and monitor routinely for liver synthetic function, and also vaccinate for hepatitis A and B if antibodies are not present. Our guidelines all suggest lifestyle modification including dietary change, weight loss, and structured, and I emphasize structured, exercise interventions. Diets should achieve a reduction in calories of approximately 500 to 1,000 kilocalories per day to induce a weight loss of 500 to 1,000 grams per week. Prospective studies evaluating specific macronutrient diets are somewhat limited. However, recent data suggests that either low fat, low calorie, or even a Mediterranean diet can improve NAFLD. It is imperative that patients exclude NAFLD promoting components in the diet, specifically processed foods and added fructose in the form of sweetened beverages. Higher thresholds of weight loss, particularly in obese patients, can improve necroinflammation and fibrosis. And exercise alone can improve hepatic steatosis, but the effect of exercise on other histologic endpoints, specifically advanced hepatic fibrosis, are unknown. And both exercise in the form of aerobic or resistance training reduce liver fat, reduce weight, and therefore we should tailor these interventions appropriately to our patient's preference and their ability to sustain them long term. Bariatric surgery can reduce fatty liver and the histologic features of NAFLD, NASH, and fibrosis, but should be individualized, particularly in those patients who have cirrhosis. Our current practice guidelines do reserve pharmacotherapies for patients with biopsy-proven NASH and fibrosis. The APASL guidelines explicitly state that patients without steatohepatitis or fibrosis should receive counseling and healthy diet with no pharmacotherapy for their liver disease. For those patients who are obese with NAFLD, treatment of obesity is the foundation of care. A 5% reduction in BMI translates into a 25% relative reduction in liver fat by MRI-PDFF, and a systematic review of 23 studies reveals that weight reduction of 4 to 10% consistently improves measures of liver fat and serum transaminase levels. Across nearly all studies included in this meta-analysis, weight loss improves liver aminotransferases. Furthermore, in this meta-analysis, weight loss consistently improved hepatic steatosis. Weight loss through lifestyle modification improves NASH for obese subjects, and in fact, the higher the threshold of weight loss, the higher the probability of NASH resolution and fibrosis regression, with 45% of patients who achieved more than a 10% weight loss having an improvement in fibrosis. The unfortunate reality is less than 10% of subjects could sustain this weight loss long term, despite having gone through an intensive lifestyle intervention. This speaks to the fact that we must really strive to develop systematic programs that facilitate not only initial weight loss, but the ability for our patients to sustain weight loss long term, such that the impact on their end organ injury and resolution of NASH and fibrosis regression can also be sustained. There is evidence in animal models that routine exercise retards hepatocarcinogenesis, and in fact, the obese diabetic phosphos mouse, which is an animal model for NAFLD and NASH, when compared to the lean wild-type mouse, when subjected to a carcinogen, develops hepatocellular carcinoma. However, when these animals were routinely exercised, not only did the risk of liver cancer decrease, but tumor burden and as well as the number of foci of liver cancer decreased. This was associated with weight loss as well as improvement in insulin resistance. And in fact, there is evidence in humans that vigorous physical activity at least 5 days per week and 415 subjects decreased the risk of hepatocellular carcinoma by 44%. A recent study in 50 patients with compensated cirrhosis who had increased hepatic vein pressure gradients, 72% of which had clinically significant portal hypertension with a hepatic venous pressure gradient of greater than 10 millimeters of mercury, who were overweight or obese, underwent a 16-week intensive lifestyle intervention. And as you can see, despite the presence of cirrhosis, 52% of patients were able to achieve greater than 5% reduction in body weight. And this did correlate with an improvement in portal pressure In fact, nearly a 10% drop. The higher the weight loss, those patients who achieved more than 10% reduction in body weight had nearly a 25% reduction in portal pressure. I'd like to transition a little bit into the role of anti-obesity approaches, specifically FDA-approved anti-obesity drugs, touch a little bit on bariatric surgery and bariatric endoscopy in the management of the obese patient with NAFLD. There have been several therapies approved by the FDA since the late 1950s for the treatment of obesity. 3 of those therapies have been studied in patients with NAFLD and NASH, that is orlistat, liraglutide, and semaglutide. Common side effects of anti-obesity drugs include dry mouth, insomnia, nervousness, increased heart rate or palpitations, fatigue, or gastrointestinal side effects. There is risk for drug-drug interactions given the polypharmacy that we see in patients with obesity and diabetes. Furthermore, the placebo-subtracted weight loss varies between 3 to 10% and is really not substantially different than the weight loss that can be achieved in the majority of patients with lifestyle intervention. There is limited data on anti-obesity drugs on the histologic outcomes of NAFLD and NASH. Orlistat decreases liver fat as measured by MR-PDFF in a parallel group open-label 24-week randomized trial of 170 patients with obesity and NAFLD. Orlistat improved the severity of liver fat by MRI-PDFF compared to routine treatment. A representative MRI is noted in the right upper hand side of this slide, where you could see a liver fat reduction from 29% to as low as 8%, and this was statistically significant compared to standard treatment. However, another study by Steve Harrison demonstrated in 50 obese patients with biopsy-proven NASH who received either diet and vitamin E with or without orlistat for 36 weeks, that it wasn't, in fact, the orlistat or the dietary intervention, but the ability for the patients to lose weight that in fact correlated with an improvement in histology, irrespective of what treatment they were randomized to. What about the role of GLP-1 receptor agonists? This is a highly pleiotropic class of compounds that decreases appetite, improves satiety, optimizes the cardiometabolic health, and decreases lipolysis and hepatic glucose production while improving pancreatic insulin secretion. Just to draw to your attention the weight loss effect of GLP-1 receptor agonists in patients with diabetes who were studied in 3 large registration trials, SUSTAIN 3, SUSTAIN 7, and SUSTAIN 10, semaglutide was compared to exenatide, dulaglutide, and even liraglutide, and as you could see, the change in weight loss was more significant with semaglutide in all these studies. Liraglutide versus placebo in a paired liver biopsy pilot study, studying 1.8 milligrams subcutaneously daily, did meet the endpoint of NASH resolution without worsening of fibrosis and was associated with a change in weight and a change in ALT. Semaglutide has also been studied in a double-blind randomized phase 3 trial in adults with obesity or overweight status with comorbidities and no diabetes. And all the subjects received standard lifestyle interventions, 17 counseling sessions, a hypocaloric diet, and increased physical activity versus semaglutide escalated to 2.4 milligrams weekly for 68 weeks. And as you could see, a dramatic weight loss effect of nearly 15% with semaglutide. And The majority of patients, 86%, were able to lose 5% or more of their weight loss, and approximately 32% lost 20% or more weight loss. In a recent study published by Phil Newsom, a 72-week phase 2 trial of 320 patients with biopsy-proven NASH fibrosis stage 1 to 3, semaglutide at every dose studied, 0.1, 0.2, and 0.4 milligrams, achieved the endpoint of resolution of NASH without worsening of fibrosis. And so while NASH resolution endpoint was met, it did not achieve the primary endpoint of fibrosis regression. The safety of GLP-1 receptor agonists in patients with NASH is consistent with that has been observed in other trials, and is most commonly observed side effect with either semaglutide or liraglutide or gastrointestinal symptoms. As you can see here in this slide, there is a dose-dependent decrease in body weight as well as an improvement in glycemic control. And in this study, while it failed to achieve the primary endpoint of improvement of 1 point in fibrosis stage, the use of semaglutide compared to placebo did suggest that fewer patients had worsening of fibrosis on the higher dose of semaglutide, 4.9% compared to 18.8% on placebo. NASH resolution has been reported with bariatric surgery, and certainly bariatric surgery is an effective intervention for the treatment of obesity and its complications. It improves lipids, weight, normalizes liver aminotransferases, and cures type 2 diabetes in the majority of patients. It also results in NASH resolution in patients who are can effectively lose more than 10 kilograms of weight in about 90% of subjects. Fibrosis resolution has been reported with bariatric surgery. Over a 5-year period of follow-up, there was downgrading from the baseline liver biopsy in fibrosis stage, with 63% of patients who had baseline mild hepatic fibrosis completely resolving fibrosis at 5 years, and 45% of patients with more advanced hepatic fibrosis having resolution of fibrosis. There were only 5 patients in this study that had cirrhosis, and as you can see, very little movement in cirrhosis despite 5 years of follow-up. Endoscopic and metabolic bariatric therapies have been evaluated for obesity, and outcomes of associated NAFLD and NASH have been reported. These tend to be small studies. Gastric, endoscopic, and metabolic bariatric therapies show weight loss dependent improvements in liver biochemistry and histologic features of NAFLD and NASH. These include the aspiration therapy, endoscopic sleeve gastroplasty, or even the gastric balloon. Small intestinal endoscopic and metabolic bariatric therapies have been reported in pilot studies, but shown to improve insulin resistance and weight loss in both dependent and independent pathways such as incretins or alterations in gut microbiota. These include the endobarrier device, mucosal ablation, or incisionless anastomotic systems. Irrespective, we do need larger randomized controlled trials to assess and define safety and efficacy in patients with obese NAFLD. So in summary, to make a long story short, treating obesity is the foundation of management for NAFLD and NASH and requires a multidisciplinary team. Anti-obesity pharmacologic therapy may be integral to the treatment of obese patients with NAFLD and NASH in clinical practice, but warrant further investigation if used specifically for the indication of NASH. Bariatric surgery improves NASH and hepatic fibrosis and is highly effective in treating obesity and the associated metabolic complications. But treating obesity can ultimately decrease the risk of progression to cirrhosis, liver cancer, and portal hypertension. Thank you very much for your attention.
Thank you, Chairman, and thank you, organizing committee, to give me a chance to present this excellent webinar. My title is Best Practice Advice from Non-Obese Lean NAFLD. This is my COI. The first, we have to talk about the definition of non-obese NAFLD and lean NAFLD. As you can see here, non-obese NAFLD for Asian is defined as less than 25 kilogram per square meter, and a Caucasian are less than 30 kilogram per square meter. Lean NAFLD for Asian less than 23 kilogram per square meter, and the Caucasian less than 25 kilogram per square meter. This definition is very, very important because sometimes both of them are misclassified or misunderstandings. Epidemiology of non-obese NAFLD and lean NAFLD. And a recent Lancet Gastro demonstrates that the overall around 40% of the global NAFLD population was classified as non-obese and almost a fifth as lean. So as you know that the 40%, it's a huge percentage. Within the NAFLD population, 90.2% of the people were lean and 40.8% were non-obese. The prevalence of non-obese NAFLD in the general population varied from 24% or lower in some countries, such as Malaysia and Pakistan, to higher than 50% in Austria and Mexico and Sweden. Among people with non-obese or lean NAFLD, 39% had non-alcoholic steatohepatitis. 29.2% had a significant fibrosis, and 30.2% had a cirrhosis. This slide shows the global prevalence of non-obese NAFLD in the NAFLD population reported in the recent Lancet Gastrohepatology last year. As you can see here, in Sweden, 70.9% shows non-obese, and Austria, 67.8%. To the contrary, in Malaysia, only 12.9%. In Pakistan, just 22.5%. This slide shows a pathogenic mechanism of predisposition for non-obese NAFLD. Some report demonstrating the higher cholesterol and the lower polyunsaturated fatty acid intake than did obese individual with NAFLD. As you can see here, high amount of fat intake, especially in fructose intake, may play an important role for the development of non-obese NAFLD. And in a patient with non-obese NAFLD shows high visceral adipose tissue areas compared to the same body weight patient without NAFLD. Specific gut microbiota signature has been reported in several papers compared to the obese NAFLD. The paper from Brazil demonstrates that The lean patient with NASH had specific gut microbiota composition that showed pathogenesis of liver injury that was independent from food consumption. Furthermore, lean NASH patient had a threefold lower abundance of Faecalibacterium plasmids and Luminococcus. Another paper from Korea demonstrating that the decrease in the sulfobibrio necid was associated with NAFLD in the lean NAFLD group. This study using the NAFLD patient without liver biopsy. Anyway, these studies have not shown a consistent composition of gut microbiota, possibly because of environmental factors and the genetic factors such as diet, region, country, and race. Anyway, further study should be required. In addition to gut microbiota signature, fecal metabolite may have an important role in non-obese NAFLD. So we conducted a multi-center cross-sectional study using biopsy-proven NAFLD, showing that significant decrease in U bacterium population compared to the obese and the healthy control, and significant decrease in butyric acid compared to the obese and the control. Significant negative correlation was found between the stage of hepatic fibrosis and the U bacterium abundance in non-obese NAFLD. Given the fact that the U bacterium is a gram-positive short-chain fatty acid producing bacteria, considering the short-chain fatty acids such as butyric acid play a role for the suppression of inflammation and stabilize gut barrier function. This kind of fecal metabolite analysis is very, very important to clarify the pathogenesis of non-obese NAFLD. Anyway, further investigation should be required. Genetic predisposition may play an important role for the development of non-obese NAFLD. As you know, the PNPL3 risk RG play an important role. Non-obese NAFLD subjects have significantly higher GG genotype than obese NAFLD. A recent CGH paper demonstrating that liver stiffness measurement, FIB4 index, NAFLD fiber score, APRI-BORD score, and ST-LT ratio are useful tests to detect F3 to F4 fibrosis in obese as well as non-obese patients, suggesting major NITs can be used for non-obese patients with NAFLD. In the APT paper published in 2018, show that histological disease severity in lean versus overweight obese NAFLD tells us being overweight, obese can raise the risk of NAFLD by 1.7-fold. The image illustrates the result yielded by the meta-analysis of the histological feature of NAFLD in lean and overweight obese patients. Relatively to lean NAFLD, overweight obese NAFLD patients tend to show a modest increase in scores of histological outcomes associated with disease severity, including liver fibrosis. From this paper, non-obese NAFLD has been considered to be benign condition. But the situation is controversial recently. This paper, this hepatology communication from the analysis of Swedish cohort, lean NAFLD at high risk for development of severe liver disease has been shown. During a mean follow-up of about 20 years, representative 12,631 person years, patient with NAFLD has non-increased risk for overall mortality in the left panel, but increased risk of development of severe liver disease was found. The hazard ratio is 2.69. This is control and non-obese and obese and lean. So the situation is different from the previous paper. Last year, the meta-analysis of the prognosis and the outcome of non-obese lean NAFLD compared to obese one is reported in the Lancet Gastro and Hepatology. The incidence of all-cause of mortality for non-obese individuals with NAFLD was 12.1 per 1,000 person years. Liver-related mortality was higher in non-obese NAFLD population than in the obese NAFLD. As you can see here, all-cause of mortality is 12.1 per 1,000 person years. But as you can see here, all-cause of mortality in obese NAFLD group is just 7.5. You know, all-cause of mortality in non-obese or lean group is 12.1. As for the cardiovascular related mortality in non-obese group, 40.0. In the obese group, just 2.4. So, non-obese NAFLD patients have a better prognosis or not is still controversial. Different ethnic group or location might lead a different of the result. Different observation period may provide a different result. So we need further studies. So we're gonna present treatment. The tips of the lifestyle modification is as follows. The basis of treatment is to improve the risk factors that contribute to non-obesity, limit intake of fructose and fat. It is reported that the higher cholesterol and the lower polyunsaturated fatty acid intake than did obese individual with NAFLD. Effort to bring the patient back to his heart weight at age 20. Effort to reduce visceral fat. The target of body weight loss is 3 to 5%. Calorie restriction must be done carefully, or sarcopenia will occur. This is a paper from Vincent Wan in the Journal of Hepatology 2018, showing the beneficial effect of lifestyle intervention in non-obese patients with non-alcoholic fatty liver disease. This is a study flow. The patient randomly assigned to the intervention group underwent lifestyle modification program. Half of non-obese patients achieved remission of NAFLD with 3 to 5% weight reduction. The same could only be achieved in non-obese patients with 7 to 10% weight reduction. As you can see here, in non-obese group, 50% of remission is achieved by the 3 to 5% body weight reduction. But the obese group, the 50% remission achieved by the body weight reduction of 7 to 10%. So tips of the exercises as follows. Although there is still insufficient evidence for the exercise therapy specific to non-obesity, the following 3 points may be important. Understand the exercise therapy can improve NAFLD in non-obese patients. Since the cardiovascular events are common even in non-obese individuals, it is important to incorporate aerobic exercise. Non-obese NAFLD patients often have sarcopenia. So resistance training should be used to increase muscle mass. Furthermore, exercise therapy is more important for non-obese patients because reducing diet may further aggravate sarcopenia. It is reported that the presence of the PNPL3 risk allele was associated with a better response to lifestyle modification, which were most effective in homozygous GG carriers of the variant. This slide shows the recommended flow chart of lifestyle modification therapy for the NAFLD patient in Japan, which is recently published in the Journal of Gastroenterology. As you can see here, in the non-obese groups, total body weight reduction recommended 3 to 5%, which is based result of the paper of the Vincent 1. The pharmacological approach, the basis of drug treatment is to ensure that complications such as hypertension, dyslipidemia, and diabetes are treated. Weight loss is of limited utility and may prove harmful in non-obese lean patient with NAFLD. Although there is no specific evidence drugs that cause weight loss should be used with caution because of the risk of sarcopenia. There are currently limited options in terms of pharmacological agent. However, there is some evidence for the use of pioglitazone and vitamin E in the treatment of diabetic and non-diabetic patients with biopsy-proven NASH, respectively. This is a summary. The 40% of global NAFLD population was classified as non-obese and almost a fifth was lean. Non-invasive assessment liver fibrosis, such as the FIB-4 index and FibroScan, are also useful in non-obese NAFLD. The prognosis of non-obese and lean NAFLD is still controversial. Both of these groups had substantial long-term liver and non-liver comorbidities. Half of non-obese patients achieved remission of NAFLD with 3 to 5% weight reduction. The same could only be achieved in obese patients with 7 to 10% weight reduction. Exercise therapy, including resistance training, is more important for non-obese patients because reducing diet may further worsen sarcopenia. Although there is a limited evidence for the pharmacological therapy, drugs that cause weight loss should be used with caution because of the risk of sarcopenia. This is an acknowledgement for my collaborator. He's a Professor Richard Eman, the professor of radiology in the Mayo Clinic, who is the inventor of the MR elastography, and he is Professor Rohit Rumba, UCSD. And this is a member of the consortium Go Asia group from the 11 countries in Asian countries. They are also the good friend of mine, and this is mine, and he is a WK Chan in Malaysia, and Sombat in Thailand, and Dan in Singapore, and he's a big guy in Vincent Wan in Hong Kong. Thank you for your attention.
I will briefly summarize patient's progression. A second diagnostic tab at 48 hours from the start of cefotaxime showed less than 25% decrease in ascitic PMN counts, indicative of inadequate response. ESBL producing E. coli was isolated from the ascitic fluid culture. Empirical cefotaxime was escalated to meropenem based on antibiogram, leading to the dramatic decrease in ascitic PMN counts after 3 days. Endoscopic band ligation was performed for the primary prophylaxis of variceal bleeding, and he was discharged after a 14-day hospitalization with TDF, diuretics, anticoagulation, and ciprofloxacin for secondary SBP prophylaxis. After 3 years of follow-up, he was readmitted to our hospital because of altered mental status. Physical examination was notable for sluggish speech, flattened affect, and astaxis. White blood cell count, hemoglobin, platelet counts, prothrombin time, albumin were low, and total bilirubin and ammonia levels were elevated. HBV DNA was undetected. His hepatic functional reserve has been improved with MELD score of 11 from previous 23. While brain CT showed no unusual finding, EEG showed 3-page waves suggestive of hepatic encephalopathy. No precipitating factors could be identified. In follow-up dynamic CT scans, he was not on diuretics, but ascites was not observed, probably due to improved liver function. And portal vein thrombosis was disappeared due to prolonged anticoagulation treatment. However, extensive collateral vessels with a spontaneous gastrorenal shunt were still remained. We assessed that hepatic encephalopathy has occurred due to spontaneous portal systemic shunt. Lactulose was administered as an anemia, and we thought that he would be an ideal candidate for Part 2. Following right common femoral vein puncture, a 6-branch vascular cyst was inserted into the gastrorenal shunt. The guide wire and catheter were subsequently removed, and the vascular plug was deployed. Additional embolization with gel foam was performed until the remaining shunt flow disappeared. No immediate complications were observed, and an immediate CT scan demonstrated interval complete absence of perfusion of the collaterals and gastrorenal shunt. Follow-up CT 1 year later showed persistent shunt occlusion, and his MELD score was improved from 11 to 7 after 1 year of the procedure. Let me briefly summarize the case. A middle-aged male patient admitted to our hospital because of HBV-associated decompensated cirrhosis complicated with SBP. After the complete resolution of SBP, he was discharged with TDF, diuretics, anticoagulation, and ciprofloxacin for secondary SBP prophylaxis. Although his liver function has been improved after 3 years of TDF treatment, he developed hepatic encephalopathy associated with portosystemic shunt. He received Part 2 and he is now on regular follow-up without any further complaint. Thank you for your attention.